Hello and welcome to Public Health in Real Life. This is Ashwin Kadambi. We are living in times where we are looking at an on increasing burden of non-communicable diseases. And what tops the list are diabetes, hypertension, as well as cancer. And today's topic is about receiving and navigating the diagnosis of cancer. And we all know that cancer is one of the leading causes of deaths worldwide and one of the most neglected and sensitive areas within it is cancer diagnosis. If you look at times in the 1960s and prior to that, physicians did not even share to the patients that they had cancer. Now we are living in times where uh, accountability to the patient and transparency is given the top priority, and there's little studies on breaking the bad news to the patient. And at the same time, we also look at the health marketing around the globe, where it's usually a half empty glass approach, scaring the patients and scaring the regular public. And therefore, there's little education into how to handle a cancer diagnosis, whether for a patient's side, from a patient's side, or from a family member's side. And of course, a cancer diagnosis is a traumatic experience. But here we are with Dr. Helya Ghaffari to discuss this area further and learn about where are the shortcomings in the system, and how we can better study and assist patients in navigating a cancer diagnosis. Welcome to the show, um, Dr. Helya.
Hi, thank you for having me. I'm looking forward to this.
Thank you. So, Helya Ghaffari graduated summa cum laude from the University of Maryland, Baltimore County, with her bachelor's in biological sciences. There, she was a scholar with the prestigious Meyerhoff program, which prepares students for careers in STEM and is at the forefront of efforts to increase diversity among future leaders in science, technology, engineering, and related fields. From there, she went to the Icahn School of Medicine at Mount Sinai to join the medical scientist training program and earned her MD PhD. She received her PhD in drug discovery and cancer biology under the mentorship of Dr. Prem Kumar Reddy. Her research focused on developing novel mechanisms against refractory and relapsed leukemia. She is now a surgical resident at Temple University with the goals of completing a fellowship in surgical oncology, continuing her research in cancer therapeutics, and ultimately delivering the discoveries to patients and improving the outcomes of difficult to treat cancers. So, welcome again to the show, Helya. We are looking forward to this engaging conversation and learn more about the shortcomings in the health system, and as well as to educate the public. So, I would like to begin right in. And so, we see that the global cancer burden is expected to increase to 29.5 million new cases and 16.4 million deaths annually by 2040. How ready and equipped are healthcare systems to handle this rise in cases?
Um, So first, I want to thank you again for having me on. I hope that my goal here is to make the C word or the cancer diagnosis less scary for people. It is a very loaded word, and it's a very diverse meaning. So I really appreciate the opportunity to help the public navigate this. So that's a really good question because it is a very rapidly changing field on multiple levels, at the level of the research and at the bedside. So, well, when we look at statistics like that, I think one thing to remember is that even though the diagnoses are increasing, the survival is also increasing. So when we hear that millions and millions are dying, we're also prolonging the course of how long they live with the disease. So there are two ways to look at this. One is that you're prolonging their life and time with their family. And if you tell a patient, I can give you this medicine and it'll only prolong your life for, on average, 6 months, of course they're going to of course they're going to want that. Most people. But on the other counterpoint is, for some people, it involves a prolonged hospitalization, possibly prolonged suffering, burden on the family, not to mention that there's also, for the family members taking care of them, a lot of times they have to take off time for work. So, those numbers actually have a lot behind them. Some of it's good in the sense that ratio is, I guess you'd say, is increasing, but it also means that it does open up new problems that we have to deal with. One is definitely at a policy level. Even if insurance covers the patient, it doesn't cover their family members that need to take off time to take care of them. Not family leave doesn't necessarily cover extended family. So if someone has to take care of a sibling, for example, or a grandparent or an aunt who, even if they're the closest living relative, family leave doesn't cover that. And of course, as with most things, if when it comes to any issues in medicine, I would tell people, you got to follow the money. So unfortunately, as most of these things go, the population that's the most impacted are those of lower socioeconomic status.
Mm-hmm.
And one of the most leading causes of cancer-related death, actually the leading cause of cancer-related death, is lung cancer for both men and women. Yeah. And lung cancer is also more predominant in people of lower socioeconomic status. And lung cancer also has the highest financial burden. Yeah. So it has, that one's in the $14,000 range versus some other, for someone with cancer. Actually, I think it would be more than that, versus someone who has like breast cancer, which actually tends to be in women of middle class, highly educated.
You said the $14,000, is that for the treatment cost you're talking about?
Yeah, for the that's just the treatment cost. So that doesn't even account for having the loss of income, right, or any additional care they would need, like at home. So that's just from just at the treatment cost, and a lot of times that ends up being out of pocket.
Right.
I feel it may actually be more than that.
Yeah.
So I think it actually may be closer to 17,000.
Right. So it's much easier to just Google and see the trends in terms of mortality of cancers, or increase in the burden. However, as you said about the survival, there's people also surviving cancers because of advanced medications and treatment. Is there any resource where people can see that kind of a data? Just like, we have the COVID data dashboard in this by Johns Hopkins and other entities. Is there such a dashboard an authentic dashboard that people can refer to?
Yeah, for sure. ASCO is a great resource. They'll give a lot of up-to-date information. That's the American Society of Cancer, I think, organization. It's terrible. I refer to everything in abbreviations that I forget what it always stands for. Oh, oncology. It was oncology. Duh.
Okay.
And then also the NIH, NCI, they're also they have a lot of resources, and they provide resources not just for giving data for patients, but also providing them with resources. So letting them know like what's available to them that they may not even know about. That's like federally funded.
Yeah.
As well as advice for family members, and provides links for support groups.
Yeah. And, cancer is, of course, as you said, the C word is to have that diagnosis is a traumatic experience, as well as it is, the reason is people equate cancer to death. Can you educate people about how do patients navigate this diagnosis? There are many survivors who say cancer is not death, but then there are numbers showing that cancer is the leading cause of death, and also I believe the pop culture always advertises cancer as a terminal disease only. So can you just help us navigate through this complexity?
Yeah, of course. This is like my favorite thing to educate patients on, because it is more of an optimistic outlook. So first we have to kind of go back to what cancer means. So cancer is a very heterogeneous disease. So it's very diverse. Breast cancer is not the same as lung cancer, is not the same as thyroid or skin cancer. So cancer just means that there's a uncontrolled, unregulated growth of cells, and that can form so solid cancer will form a tumor that those cells can then leave there where they primarily are located and go to other organs and disrupt. Other cancers like leukemia, their issue is that because it's unregulated growth, you're not making the cells that you actually need to survive. So the actual growth of the cells isn't necessarily what ends up harming people. It's the impact they have on normal physiology. So if you have metastasis to the brain, to the lung, or to the heart, that's what affects people. So when we say cancer is incurable, it doesn't necessarily mean it's terminal. Now, with that said, there are cancers that are have a more not as optimistic of an outlook. I think ovarian cancer tends to have a poor prognosis unless it's caught early, but I'll come back to that one. Pancreatic cancer and cholangiocarcinoma is a particularly deadly one. What's interesting, though, is like, for example, cholangiocarcinoma, it's not deadly because it metastasizes everywhere. It's deadly because you can't live without a biliary tree. So cholangiocarcinoma is a cancer of the biliary tree.
Okay.
And you can't live without that.
And where is
you can't do surgery on it. It's usually not resectable, and the person ends up dying of liver failure, and tend to not be transplant candidates. Versus if you have, you can have lung cancer or maybe lung cancer is not a good example, like colon cancer that's invaded and metastasized, but the metastases are like, if they're caught incidentally, they're not really affecting anything. And in that case, you kind of have time to go through multiple treatments. And the goal there is not necessarily to make those tumors go away, but to make sure they're not impacting normal physiology. So people can walk around for a long time with tumors as long as it's not affecting their quality of life or their ability to live, breathe, think. I list all these things because quality of life means different things to different people. For some, as long as their heart's beating and they can breathe, like that's living to them. For some people, it's like if their personality changes, then they're gone. So that's why it's really important for physicians to have these conversations with their patients, and for family members, if they're the proxy, to know like what do you want? Because that's different for everyone. So this is kind of like a really long answer.
No.
But it's that's like kind of the first thing I like to remind people. The other thing is, saying the hashtag cure for cancer.
Yeah.
It's really great with raising funds. But the truth is it's not realistic. So when we are thinking of treating a patient with cancer, our goal is to extend their life and maintain their quality of life.
Yeah.
Of course, we want them to have no tumors because that's the that's the ultimate goal, is to completely get rid of tumor burden, because then you don't have to worry. But once a cancer patient, always a cancer patient. So if you have someone that comes in with stage 4 lung cancer, your goal really is to get them to stage 1 and then have it so it's equivalent to having diabetes.
Yeah.
People live, it's just interesting to me because people get the diagnosis of diabetes and they're upset for a while and then they function normally. They check their insulin levels, or they take their medication and they live a long life. Yeah. That's kind of what my goal as a researcher is with cancer. And in my mind, that's what a cure is. Yeah. If I can have someone live their best life for a long time, then I think we've done our job, even if they have a tumor somewhere, but as long as it's not doing anything.
Right. I think, in the decade or so, the public health has done a good job with educating the public about the basic health in terms of, checking your blood pressure, checking your blood glucose. But, or even, certain cancers, for example, there's so much of drive about having your colonoscopy by age 50. But what are some other areas where public health is slow in terms of educating the public about preventive measures?
Sure. Well, one thing I want to point out is they've actually just reduced the age, and this is perfect because this is like to your point, which is they reduced the age to start colonoscopies to 45.
Okay.
But the only reason I know this is because I'm in the field and in the hospital, but most patients are surprised to hear that.
Yeah.
So again, I kind of want to go back to policy because it is hard to educate people. Most people don't want to have these conversations. It's one more thing to think about. And I think where policy would help is providing more access to primary care. So a big issue among healthcare providers at all levels is that there's a high need for primary care physicians. There's not enough of them. Most people that go through med school end up in a lot of debt to do so.
Yeah.
And unfortunately, to become a primary care physician doesn't compensate you very well.
Yeah.
So if they are very skilled, they're going to want to specialize and get the income that they do, that they feel that they deserve. I think that's rightfully so. So I think if we provide more incentives for people to get into primary care. On the patient side, it's very difficult. You have to have insurance, and you have to have access to primary care, and that's not feasible. A lot of people what they end up doing actually, especially those of lower socioeconomic status, is using the emergency room as their primary care. And the emergency room, that's not their job. That's not their job, but they do it. They don't turn anyone down. That's what they do, but they're not equipped and they're not trained to know about screenings.
Yeah.
And the truth is, like, if there is a cure for cancer, it's prevention.
Yeah.
So the screenings are the biggest.
Sure.
Is what really needs to is going to make the most impact on prolonging life, and I think the best way to educate patients is through their PCPs or the primary care doctors, and then we have to provide them access to it. It is rapidly changing. Like they're always changing the screening mechanisms, and I think the only way for a average person to be able to keep up with it is to line it up with their annual appointments, and then that way their doctor can tell them, oh, it's time for you to check this. And then also if we educate other providers, not just the MD, but a lot of people go to the pharmacy. So I think a really great idea would be to educate pharmacists. So that way when they see certain patients reach certain checkpoints, they can remind them, oh, you're due for a mammogram. Now's the age that you start. So identifying like regular people that have the foundation to properly educate, but patients have more consistent access to, but then also providing more consistent access to medicine.
And what do you think is the role of health professions other than physicians? For example, we have surgical assistants, then we have physician assistants, and any PCP appointment in the United States is 20 minutes. And in 20 minutes, the patient cannot remember every question they want to ask the doctor. The doctor does not have all the time to look at do a 360-degree view of the patient who comes probably every month or every quarter or every 6 months or maybe every year. So how do you think? What role do you think physician assistants can play in educating the public and also having that increased access to a health provider for the public?
Yeah, so I think the role of physician assistants and nurse practitioners is growing in healthcare, which I think is a good thing. It's a little bit controversial because they don't do a residency program, which provides the training, or they can if they would like. I support it because I think that, I've worked with them. I think their training they're educated, they know how to take care of patients. And I think that they're a great resource to help bridge that gap. I hear it from both sides. I hear patients complain that they didn't get enough time with their doctors. And then I hear doctors say, like, I can't keep up with all my patients and my notes and I'm overwhelmed. So everyone's spread thin. I think what we need to do is increase the manpower, and PAs and NPs are a great resource for that. Something else that's, we don't really talk about too much is my chart. So no one has really talked about having even access to that and knowing that you can message your doctor that way and not necessarily make an appointment, and it's free. Your doctor can set you up with it. But again, that comes back to that foundation that you have to have established a care and at least one doctor who you trust. Right. So, increasing the access to for people, whether that's through insurance or through community efforts, and increasing, opening the doors to increase the type of providers that can do certain services. So there's a lot of efforts being made at the state level to give PAs and NPs more independence, that they don't necessarily have to be under an MD or need an MD to sign off on everything. Again, this is a little more controversial. I think, there's points to both sides. But I think that if the two sides, rather than opposing each other, which they tend to do, I think if they try and come to a common ground and find something that, recognize the advantages of each one and the struggles of each one, then we can actually resolve the bigger problem, which is that there's just not enough healthcare to go around.
Sure. And Helya, you're a health provider yourself, and there's very little research done in terms of what the doctor goes through when communicating the bad news to the patient. I don't even want to say bad news anymore, about the diagnosis to the patient. Are you able to share any experiences you have had going through sharing the information, and how maybe a particular patient took it right? A good example of how a person approached it, and what additional studies can we do to improve physician education in communicating the diagnosis?
So I'm still in training. I'm a resident, and at this point, I do tend to I it's the role of the attending, my supervisor, to tell the patient the first time that when they get these news. It doesn't always happen that way, but I've been lucky that I've been working under attendings who do own that responsibility. A patient needs to hear it from the head doctor for first. They can, but I've observed it more than a couple times, and it's and I'm fortunate that I got my medical training, my med school training at Mount Sinai, Icahn School of Medicine at Mount Sinai, where they're a leader in palliative care. And palliative care doesn't necessarily mean end of life, but they are also trained in how to deliver unfortunate diagnoses or poor prognoses to people. And there's an acronym they use, NURSE, where they it basically focuses on. I'm sorry, I lost my screen. It focuses on giving the news actually straight up.
Yeah.
But respecting the patient's autonomy. So the first thing, N stands for name.
Okay.
So you give it a name, and they tell us also to start with the first word should be something that prepares the patient. So something simply like unfortunately.
Sure.
So it says like, unfortunately, the biopsy came positive for cancer.
Yeah.
And then you pause.
Yeah.
And part of that is, one, you got to be clear with the patient. They're overwhelmed, they're having a lot of feelings, and if you beat around the bush saying all these medical jargon, like, they're not going to understand it. Yes. And they're going to be going through all these emotions, and it's doing a disservice to them. Then U stands for understand, so that kind of goes along with the empathy, having like, I understand that this is a difficult thing to hear right now.
Yeah.
And R is respect. So whatever their reaction is, you respect that. S is support, and which is kind of obvious.
Yes.
And E is explore. So kind of this is a good opportunity to talk to them about how they're feeling. And this is also this effort isn't just a one and done. This may, there's throughout multiple times during their treatments, and as they continue getting workup, to delve, to categorize what kind of cancer they are, because even if you know what organ it is, or what type, there are like all these subcategories, which will then determine your treatment. And then from there, it'll be like, oh, if you're a candidate, then it'll tell if you're a candidate for clinical trials. So you end up having this conversation multiple times with them. And at every point, the important thing, I think the most important part is the explore and see like how they're feeling. Are they comprehending things? There's a lot of, I think if, people were to look into, anyone that's interested in healthcare at any level, if they want to look into how to prepare in delivering bad news, which eventually you end up doing, whether it's for cancer or another condition, then I think looking into like palliative care articles, they're probably, they're the best at it. Now, I haven't, because I'm not an oncologist yet, I haven't had that conversation with a patient, but I have represented the surgical team at family meetings.
Sure.
So these are when things are starting to get complicated, and we've come to an impact, like a point where the answer isn't necessarily obvious. Yeah. So it could be, discussion of end of life care, or discussion to have a surgery that has a high morbidity or a high mortality, or a surgery like, does a patient want to try and have a surgery that could actually leave them disabled? It'll extend their life, but they'll be disabled.
Yes.
A lot of times the patient isn't even present for these conversations because they're debilitated.
Yes.
So I've participated in those. My experience has been, again, I've kind of gone, even though I'm talking with the family, they already know what's going on. It's not necessarily delivering the diagnosis, but it is delivering the news. Like, unfortunately, if it continues in this, I try to go around the bush. Unfortunately, we're going to need to amputate the legs.
Yeah.
I say it like that, and it will not necessarily extend his life.
Yeah.
So something very clear that way. And then, I mean, a lot of it is also just people have all kinds of reaction. It's kind of surprising how effective you can be just sitting and listening. I've had patients that the work started off the conversation so angry, and then at the end of it, they're like apologizing to me. And I didn't say anything during that time. I just like sit there and listen. I think it's a very sensitive area, and that's why actually these are not conversations you have in the emergency room. These are not conversations you have in a 15-minute appointment. These are conversations you have in a doctor's office, and usually you want to have a friend or a family that you trust with you, if the patient would like. I have seen it before delivered in the emergency room. It made me very upset. And there's a lot of efforts being made right now to educate providers on how to do this. Aside from, palliative care has their mechanisms, but there's also the NCI has an initiative, and they actually now there's a Journal of Cancer Education.
Yeah.
So it provides education tools for providers, NPs, PAs, MDs on how to talk to their patients.
Okay.
And they also provide resources for patients themselves. One of I don't know, how did I forget it? One of the best resources for patients is the American Cancer Association.
Sure.
So
this new journal sounds something more informative, and it's good that they have this journal on education, cancer education. Look, such an important side, and glad that there is a journal that's focusing on this area.
Yeah, I think that the more we discover about the disease, we're realizing and that it is, like you mentioned before, it's changed so much from the 1960s. I mean, it's changed so much from 10 years ago that we're realizing that we just need to be better about educating the public. And one of my mentors says, either you talk to the patient a lot at the beginning or you talk to them a lot at the end.
Yes.
So you kind of have to, at some point, you have to start talking with the patient.
Yeah. And it's also about giving time for the patient alone versus giving the patient all the resources they need. Having that balance for the patient at that time. And in terms of other resources that are available, we talked about palliative care, but I want to really focus also on racial equity, and how do we ensure that physicians are culturally competent. For example, we have we also have to consider situations where um, when a woman goes for an ultrasound, there is and let's say the male is the ultrasound specialist, the radiologist, ultrasound specialist, then there's a female chaperone, right? So similarly, should there be a chaperone who represents the patient's uh, belief uh, belief or racial, ethnic representation, um, to deliver the news?
Yeah, I mean, I think that was a really big improvement in how we deliver care to women, is making sure that there's chaperones there and checking in with them. I think that should expand. One of actually the things that I noticed when I was participating in a prostate cancer screening was that there was no advertisement for transgender women. So they still have their prostate. They need to be screened. But but well, they weren't there, and I was imagining it'd be very uncomfortable for them
Yes.
to go there, and so I think that there needs to be representatives for LGBTQ and then also religious.
Yes.
So there's some pockets already in place that I think are good models. So the Orthodox Jewish and Hasidic Jewish populations in New York, they'll have a liaison. So someone who's usually already part of their community that they trust,
Yes.
that will then but who also has a relationship with the hospital.
Yes.
So they've been able to help bridge that gap between the cultural beliefs and their comfort, as well as, but also making sure that they have the best possible health care.
Yeah.
And then we have to remember that everyone's on the same team.
Yes.
And it's usually, there's oftentimes when there's a disagreement, it's lack of communication and understanding.
Yes. And so, the premise of this conversation is, ensuring that we positively affect people's perceptions, or rather, positively affect people's negative perceptions towards cancer diagnosis. And so, that is going from point A to point B. So, in going to point B, where do you see the largest gaps in all the layer that we have spoken? If there's one particular gap that's the largest that we need to urgently fix, so people are properly, if we can have of course, it's going to be a difficult diagnosis, no doubt, but if we can make an impact in one of those areas, what would it be?
Oh, wow, I have to think about this. I think that letting patients know that there are, the first thing they do is go on Google.
Yes.
And then they look at the, American Cancer Society, so ACS, which is a great resource and it gives you lots of stats, but it's made for the layperson, for the general public. It doesn't tell you the most up-to-date research that's undergoing peer review and hasn't quite been translated yet. There's actually a really large gap between when discoveries are made and when they reach patient knowledge. Oftentimes, it's not until patients get diagnosed and are in the middle of treatment that they're like, oh, I had no idea immunotherapy was a thing. I mean, now we know immunotherapy is a thing because we talked about it in the news, but the truth is, it was probably already being researched and clinical trials were starting to be underway before it reached general public knowledge. A lot of people don't realize that some of their, when they were getting antibodies, that's immunotherapy.
Yeah.
And then there have been advances within it where we can reprogram your immune cells to target cancer. Yeah. So I think getting information to patients, quality information to patients, is a big gap because I feel like if they know everything that's being done in the background, it gives it less of a hopelessness.
Yeah.
But with that said, I say that as if it's easy, and the truth is, and this has happened multiple times, where CNN will report something, and it's that's not quite true. They kind of oversimplify, or something will get the hype. I think it was 5 years ago, they talked about, it's always some college student for some reason, or high school student that's discovered something in the blood that there was this one college student that discovered that there was a marker in the blood that can help detect pancreatic cancer. But once it goes through all the trials that you need, they realized it wasn't actually affecting anything. So it's you have to find that sweet spot where, okay, this is promising, but it's, you don't want to wait too long to also deliver it to people because actually I went to a talk by renowned cancer scientist Bert Vogelstein, and he said something that really stuck with me, and I was early in my researching for my PhD, where he said you don't have to wait till all the research is complete to deliver things to patient, because if you do, at that point the ship has sailed.
Yeah.
So it's a cycle. So
Yes.
you find something that you think will be effective or shows promise, you deliver it to the bedside, and you get the information from the bedside, bring it back to the clinic. So it's a very dynamic process. And I think kind of showing patients how the sausage is made
Yes.
in a weird way would help them see that this isn't an end all.
Yeah.
A stage 4 cancer doesn't mean that they're a hopeless cause.
Yeah.
It doesn't mean that it's an easy diagnosis. It's hard. They're going to go through chemotherapy, is one of the hardest things anyone will go through. And then also surgery is hard. You know, patients will expect to come out, hopping out of bed. It's like, no, you just had a part of your organ taken out. Like that's not easy. And then after we do that to you, then we're going to shoot you with radiation, and then we're going to poison your body.
Yes.
Oftentimes the treatments feel worse than the disease themselves. So, now that I said that depressing thing, I think just also realizing that there is a lot of efforts outside of those that are being made, and there's always a constant strive to improve things. So that was, I didn't mean to make that take a dark turn.
No. But really, if you look at, I am glad you brought up the CNN example. Same thing with, we are battling fake news in social media. And do you think social media channels like Facebook and Twitter and LinkedIn, just like they are battling against fake news in our politics, also need to take responsibility in educating the public and battling against fake health news?
Oh, absolutely. It's such a problem. I mean, even with the anti-vaxxing, like anti-vax is the big issue. People are seeing this thing where people were showing, there was this image being spread about how the fluid in a vaccine has like mercury in it and all these other chemicals. But yeah, I mean, it's such a problem. I'll have relatives even send me things saying, oh, it says that if I follow like a keto diet or a paleo diet, it'll help, it'll cure my cancer. And it's like, no, if there's any anecdotes of that, likely the person was misdiagnosed.
Yeah.
Or likely it was a coincidence.
Yeah.
No, that's not to say that changing lifestyle doesn't affect cancer. It absolutely does. I mean, the classic example is cigarette smoking and lung cancer.
Yes.
Eating healthy, of course, helps. Having, I mean, and there has been evidence showing that red meat increases the incidence of colon cancer. So all these things, but there's so much fake news in healthcare, and especially because the problem with social media is it tends to be the bubble. So in the same way that everyone follows the same political side, and then it just gets more and more extreme, the same thing happens on the health side.
Yeah. And how about the role of family members? What are some resources that we can provide family members and people in the public, because they are not the ones going through the diagnosis. They are not going through that particular situation, but they end up, just like even any cancer patient would end up out of the world, having one fine morning having that diagnosis. Just like that, there are multiple there are all these people surrounding that patient who one fine morning learns that their family member has a cancer diagnosis. So how do we make sure that there are educational resources for them, whether it is multimedia resources or through books or through people resources? How do we ensure that?
So I'm sure yourself, myself, and anyone listening knows someone who's been diagnosed with cancer, at least. So this is definitely a real, I would say like hidden issue. Like it's something that is very easily disregarded. But it does pose a lot of problems. Even, these are the people that patients, when they're debilitated because of the chemotherapy or because they just underwent huge surgery, these are the people they rely on to get to them to their doctor's appointments. Because, as I alluded to before, with the cost of healthcare, they have a lot of appointments every week. They have to go for chemotherapy if that's what they're doing. Some radiation is daily. They rely heavily on these people to take them, and that can, there is increase of depression, economic instability. So in the family members, and anxiety. So one thing is we need to remind healthcare workers, nurses, PAs, MDs that the individual is not their only patient, the family is. That's actually something else I picked up from the palliative care department at Mount Sinai. That's kind of part of their philosophy. Is you check in with the whole family. And that's also the concept behind family meetings. Now, for individuals themselves, there is some research being done. So there's a research being done right now for pediatric oncology because I think that's of course, that's the worst case, like the most devastating news a parent can ever get. And of course, it's the parent that's taking care of them, or the guardian, whoever, so they're like the hallmark of family effect of the family. So there's some research being done for pediatric oncology on how to first learn and identify what are the obstacles in transitioning from the hospital to the home. Because while they're in the hospital, it's emotionally tough. It's grueling, especially now in the pandemic. It's scary to enter a hospital if you're not sick, or even if you're sick. But at least while they're there, the patient's getting the care they need. Now, eventually, they're going to leave the hospital and can continue. A lot of therapies are outpatient from home. So, and a lot of times, what ends up resulting in a readmission is because something that was supposed to be done at home wasn't done. Or couldn't get done, or there were some barriers. So there's research right now being done identifying what are these obstacles, and once these are identified, then we can work on targeting them. So is it that there's not enough help at home? Parents have to work, and then extending right now for Medicare. So this isn't even with pediatrics, but with elderly. Medicare doesn't really cover home health aides unless they're really debilitated. It's very little. And I already mentioned family leave only covers like immediate, like someone in the nuclear family, I think parents and children. So I think broadening the access for these things will help the families. I don't really like to tell people, just go do research on this, because they're already doing so much. I really would like to defer the responsibility of helping the families to the community. So the hospital community and policies. I think once these other things are set in place, then it'll make it easier for the family to do whatever they need to do to support themselves and their loved ones. Because ask them more than that is a lot. But until then, there is ACS has a lot of resources, and looking into group therapy, because that's another really rich source of information. And we have patients talk to social work all the time. They're a breath of knowledge.
But then, when we talk about the community at large, we see that the community follows money.
Yeah.
And there is a less amount of investment made in prevention. In public health, usually there are multiple layers of educating the public at multiple levels or multiple times of the diagnosis. But usually that is what is neglected usually, because there's not a financial ROI there
Yeah.
to that education. But in terms of, can you give an example of home health aids?
Oh, it cut off. Can you repeat your question, please?
Can you give an example of home health aids that Medicare does not cover?
Yeah, I think I'm not completely certain, but I think right now it's that home health aides, Medicaid only covers for 2 days a week.
Oh, okay, okay.
Yeah. So otherwise you have to, it's private.
Okay.
I think the exceptions are if someone's actually bedbound.
Okay, gotcha.
And a lot of times, at that point they're in nursing homes.
Right.
But there are, based off states, there are different states that offer more. So in Maryland, for example, the government will actually pay more to family to keep them out of nursing homes, because nursing homes are another form of there's a burden there, to the financial burden to the society.
Yeah.
There's different levels. There's like the nice nursing homes that are obviously private, but then there's the public.
Sure. And what do you think is the role of government? For example, simple interventions like having a bicycle lane increases people exercising in the community. But you have worked, you have studied your MD, PhD in New York, where you have people that are homeless and people who are millionaires. Then you have people who have went to Columbia University, and then people who are probably high school dropout. So you have that, that mix of people there. So what can, whether local, regional, and national level governments can take action to, invest in prevention?
Yeah, so there's community health fairs. That was something. Mount Sinai is located. The main campus is located in East Harlem. So every year there's a community health fair. It's completely free. Patients can get all sorts of screenings done there, or scheduled for screenings. A lot of the physicians or doctors' offices, they'll have offices that are, they have office hours or certain officers that are designated for that take insurance. And then because if they're able to get their practice sufficiently running financially, then and if then they'll actually do pro bono work.
Yeah.
I think if there's policies that incentivize doctors to do that, that would help. Like if I don't have enough knowledge on politics or policies to come up with something like that. But right now, it really just depends on just someone being having that nature to want to do that.
Yeah.
Other things, screening is the best, and starting, I think, at an early age, like letting people know and not taking away any stigma.
Yeah.
I kind of like to give the example of HIV model. I think, we saw how HIV went from this complete, it's still a little bit of a stigma, but by educating people on it very early on at a young age, and then our approach to it on all the marketing and, getting STD screenings has really helped in making it not a big deal to go get tested for HIV.
Yeah.
I think if we did the same thing, something that's like really sensitive for people is still colonoscopies. Even though we talk about it, you and I mentioned it nonchalantly, for a lot of people, and you alluded to cultures. For some men, like the idea of having a colonoscopy is very invasive.
Yes.
And I think having just before that, having the conversation with them, not at the time where they're due for one, but beforehand. Just making it a normal thing, common. And same thing for, the HPV vaccine and getting pap smears, making it just like a normal thing.
Yeah.
So that would, I think that would really help. That's not so much answering your question, but I realize it's not really an effort made by the local government. But having, I think, initiatives driven by them, like at community health fairs and making it part of public education.
Yeah.
Or even like, public service announcements.
Yes.
I think those are definitely efforts they can make. And then also, it does come down to the hot topic of insurance.
Insurance.
I think even like, there's some insurance companies that are actually, and again, on their own, incentivizing patients to go get screenings.
Yeah.
And I think making that more widespread.
Yes.
Having, telling people, oh, if you go get your colonoscopy done, like at 45, like you're supposed to, and not putting it off till you're 55, well, you'll actually get a cut. You'll get a decrease on, or you'll get a refund on something.
Right.
Or like tax refunds. That's a great way to get people to do things.
Absolutely. Yeah. And also, I believe, when we talked about community, celebrities have a huge impact on these kinds of activities. I watched Jimmy Kimmel episode where he got his colonoscopy, and they filmed a certain not the colonoscopy, but they filmed that episode of him going to the hospital, and I think even Katie Couric joined that episode. So I really feel like even in this COVID pandemic, celebrities have a huge role in terms of driving people to get vaccinations through social media or through their other channels to their fans.
Yeah, you're absolutely right. I think they have, as whatever your opinion may be, the reality is that they have a strong platform, and I think they also have an ability to span multiple socioeconomic like statuses. You mentioned like the high school dropout. They like watching was it Keeping Up with the Kardashians just as much as the Columbia student. And so stuff like that. And I think a really great example is Angelina Jolie getting her prophylactic mastectomy. I think she was just open about it and said, she has a family history of breast cancer. She carries the mutation and she's done having children. So she decided to go for the prophylactic mastectomy.
Yeah.
I think having kind of, that earlier you mentioned about how to educate patients more on screenings. I think if there's, efforts being made to identify people who the public just seems to respond to. I'd even I don't know if you could ever get them on board, but Donald Trump's followers, let's get something out of that.
Yeah.
I don't know if you'd ever get him to agree, but if you can imagine someone with that kind of grip on people, just telling them to get screening. One thing that's really, not known, we've mentioned colonoscopy, but something else is lung cancer screening. So now if you have any smoking history, you should get a chest x-ray just once. It's not even an annual thing. It does, that's shown to help reduce the deaths in lung cancer. So because it's caught earlier.
Yes.
Something I kind of referenced earlier is ovarian cancer. So this is like a little bit of an aside, but one of the issues with multiple types of cancers, and when we look at these stats, is that they don't present with symptoms until they're very advanced. And the reason that colon cancer has made such progress is because we've identified a way of recognizing it before it's caused issues.
Yeah.
And health insurance cover it.
Sure.
So it comes no cost to the patients. And this is where research is really limited. We just don't have anything to identify ovarian cancer yet. Same thing with pancreatic cancer. And at one point, same thing with lung cancer.
Sure.
But now we have the chest x-rays. Is it as effective as colonoscopies? Not really. They, really, there's still a lot of work that needs to be done. I think the dream is to have one blood test.
Yes.
And there's certain markers we test for, but they're very non-specific. And one thing we do worry about with cancer, as opposed to other things like diabetes or high cholesterol, is the false positive rate has an impact on people. Yes. Telling someone, oh, the screen came back positive for cancer, like that's devastating.
Yes.
Mm-hmm. So, it's something that you have to walk gently around. And it's why we don't just do that for people, because just because something has a high sensitivity, it'll pick up something, doesn't necessarily mean it's specific. So it means that it has a high false positive rate. So when people are wondering why there's no screening for these things, it's a lot of it's because of that. There's nothing specific enough that won't unnecessarily alarm people or make them go through unnecessary treatments
and troubles.
Yes. Well, I'm sorry, that was a little bit of a digression from what you said, but I wanted to get that in before.
Yeah. Well, Helya, this was such a engaging conversation and such an instructive conversation about receiving and navigating a diagnosis of cancer. And we touched on a lot of issues, not only related to diagnosis, but also about prevention, more importantly, and the role of government and media and also the perceptions of patients, health providers, and the role of other health professions and their impact on educating the patients after the fact that they have visited their doctor. Mm-hmm. And having that access not only through not only that monetary access, but more importantly that moral aspect. Mm-hmm. Having that moral support to the patients. That's I believe the thought of the entire conversation, really.
And that's incredibly well said. That's exactly, I think that's a major goal.
Yeah, definitely. Well, thank you so much for coming on our show today, and we look forward to having you in future episodes. And of course, your we recognize that your knowledge spans above and beyond this topic. We would love to have you in additional conversations.
Thank you so much, Ashwin. It's always a pleasure to talk with you. And, I still have a lot to learn, but I'm trying to take the advice of Bert Vogelstein and not waiting to learn everything before I start sharing what I already do know. So thank you for the opportunity. I think I hope I was able to kind of help unveil this, it's a devastating diagnosis, but make it a little more digestible for people.
Absolutely. Thank you. Thank you so much.
Thank you.
Take care.